How's it going, everyone? Welcome back to the channel. My name is Gianluca, aka Dr. Calcagno, and I'm a final year family medicine resident, currently back on rotation in OBGYN. So here's the deal. So far on the channel, I've done a few reactions to other content creators' videos, a few about rural medicine and family medicine, but I had a few people in the past leave some comments in the comment section below that you'd like to see my reaction about some of the specialties that I've rotated through so far in my family medicine training. Now, when it comes to my experiences with OBGYN so far, in medical school, you need to do a 6-week mandatory rotation, and then in residency for family medicine, it is a 4-month block on labor and delivery as well as gynecology. I myself, though, chose to do an additional 1 month of training in women's health, specifically because I know that starting in July of this year, I'm going to be opening my own practice. And I think that with family medicine and general practice in general, this is sometimes an area we drop the ball in when it comes to women's health, and I don't want that to be me. This is a large part of my patient population, and I want to be as competent with women's health as is possible. So I spent a lot of time with the obstetricians and the gynecologists lately. So we'll get to today's video. This one is called When the ER Consults OBGYN, starring Dr. Jennifer Lincoln. The channel, this video is by Dr. Schmidt, and I would highly suggest that you guys go and look this channel up and watch a few of the videos because they're really, really funny.
Hey, it's GYN returning a page.
Hey, this is Ben in the ER. Could really use your help down here.
Okay, what's going on?
I've got a lady who's, well, she's bleeding.
Bleeding?
Yeah, I think she's bleeding from her, her vagina.
Okay, I'm gonna stop it right there for now. A few things we've got to go over here. First of all, you could see the fear in Dr. Schmidt's character's eyes over here, and to be totally honest with you, yeah, sometimes I might have actually seen that in person. I'm not gonna name any names, but it does happen sometimes, and I think a lot of this comes from really it's a lack of training, a lack of experience, a lack of interaction with this patient population, those being anyone that's pregnant, anyone that's actively on their period. I think what happens a lot of times is that as you go through medical training, unfortunately you have specialists that end up in areas where they're seeing only one particular type of patient, and then after a while you become more and more removed from the general population, and if you don't see someone in a while, pregnancy especially has many different complications and different doses for drugs and things like that that make people feel a little bit incompetent, turns into fear, and as a result you get people that just don't want to interact with people that are experiencing vaginal bleeding, pregnancy, or any number of other women's health related issues. Now, the other thing to go over is the concept of the inappropriate referral. And I'm not gonna lie, I'm not gonna say that I myself have never made an inappropriate referral in the past, especially when you're going through residency training, especially right in the beginning when you're very new to being by yourself and you need some help, so you call someone. Maybe later on in your training you could have handled it a little bit better. But I'll just say that never in my life have I ever consulted OBGYN, nor will I ever, for a patient who is experiencing vaginal bleeding and then not being able to say the word vagina to the OBGYN when I call them. For those of you that have never spent a lot of time on the OBGYN floor at the hospital, and I'll just talk about where I am right now, there's about 4 hospitals in the region. Only one has OBGYN doctors that are always on call. And the way it works is there's more than 10 of them, and they work in 12-hour shifts. So it's like 8 in the morning to 8 at night, and then 8 at night to 8 in the morning. And usually what happens is that the OBGYN floor is crazy. It's pandemonium all the time. There's always someone delivering or having complications with pregnancy, unfortunately. Maybe there's an emergency C-section that has to happen, and all of the OBGYN doctors wear like a necklace with a badge on it that's their pager, and it's a Vocera pager. So what happens is, if you are going to page OBGYN from the emergency department, for example, on the other end of that there is a OBGYN doctor actively trying to help deliver a baby. People are yelling, there's a whole bunch of different individuals in the room, maybe pediatrics is there too, and all of a sudden their pager goes off and it goes, Vocera call from the emergency department, accept. And if they click yes, and you're stuck with this kind of consult here where it's really not something that they should be picking up, they could get justifiably a little bit angry with you.
Her vagina?
Yes, that. I think so.
How much is she bleeding?
I would assume a lot. I mean, she came to the ER for it, right?
Did you see it yourself?
No. Oh, God, no, I didn't.
So she's not on her period?
I don't know. Hey, Sharon, can you ask 15 if she's on?
So I think we could all be in agreement that that is definitely like mandatory standard information that you should have when you're making that call to consult OBGYN. Now, moving on to the bigger picture here, and just me wanting to share my firsthand experience as a male doctor working on OBGYN, and as someone that wants to be able to practice women's health in my office because it's a large part of my patient population. And the way it works here in Canada is you can't just show up to an OBGYN office, which means that if you go to your family doctor looking for a referral, it could be months before you're able to get into an OBGYN office. And I think for that reason, it's really important that I'm comfortable doing everything that I can in my office, from birth control counseling, Nexplanon, and IUD insertion, talks about endometriosis and workup for things like uterine fibroids. All of that can be done in my office. Now, I've worked with male gynecologists and they were amazing. And I've worked with female gynecologists and they've also been amazing. But one thing that I'll say is that when I'm in my office and I have a guy in front of me, they'll often make comments that they feel very comfortable talking to me about their prostate-related conditions. Similarly though, there have been times, especially in medical training, where for one reason or the other, sometimes there are even religious or cultural reasons involved, where the women who we're dealing with did not want me in the room taking a history, did not even want me in the room with a preceptor to learn, and I'm not oblivious to the fact. I totally understand why, but I do think it's really important that we don't let those experiences deter us from getting training in more specialties in women's health.
My period? What? Are you sure?
Hello?
Hey, sorry, my nurse says that the patient's too old to be on her period.
What? How old?
67.
Quick pause. Fun fact, average age of menopause here in Canada is 51. We say 51, 51, 52, and this is a number that will change in different parts of the world.
Okay, what did her pelvic exam show?
Pelvic exam?
Did you do a pelvic exam?
No, sorry, she prefers an OB to do it and she prefers a woman to do it, and it's shift change down here, so I actually just got signed out. Also, we only have the disposable speculums down here, which are kind of uncomfortable. Also, she declined an exam, I think.
Wow, that's a lot of excuses.
I'm pretty sure that's actually every excuse. I don't know if I've ever heard another excuse or another reason that someone's told me actually that's not an excuse as to why they didn't want me to do a pelvic exam. I will say the one thing that I do always, doesn't matter who I'm working with, is that when I have to do a pelvic exam, I'll always bring a chaperone in if I'm in the emergency department. And we don't just do this for female pelvic exams. We started doing this as common practice for many different things. Even if I'm doing a digital rectal exam for an elderly male, for example, and it's just a good idea to have an additional person there because it makes both parties feel a little bit more comfortable, and also it just helps protect you from a legal perspective. Quick tips for any medical students out there or people that are relatively new to practice. Number one, the speculums are really, really cold. So I'll always try my best to, if possible, and I'm wearing gloves, to warm it up with my hands a little bit because they're made of metal. They don't conduct heat at all and they can be really, really cold. Number two is you apply generous amounts of lube, and the hospital has no shortage of lube. Like there's lube in almost any drawer in the emergency room. And the last thing that I'll always do is make sure that my patients know that at any time they could let me know things. They could talk to me as I'm doing the exam, and I'll take their input in, knowing when to stop or when to advance a little bit more slowly, or just when they're not feeling comfortable. I think that's probably the most important part of the exam, to have that open dialogue where your patient knows that they could talk to you and tell you different things as you're doing the exam. One thing that I found really difficult, especially in the beginning as a male practitioner, is when my female patients would ask me about what the exam would be like. Like I had questions about, does the speculum exam hurt if it was their first time having a speculum exam? And if this was something that I had personal experience with, I could give definite answers, but really all I could offer in situations like this was that some people tell me that yes, the exam does hurt, but then some people tell me that the exam feels uncomfortable, and some people say that they really don't mind it much at all. Similarly for the IUD insertions, it's a spectrum of different things, and it depends on technique and how exactly it's being done, but I'll have people ask me if IUD insertions hurt, and really it's the same thing. I'll try and tell my patients as best as I can that I hear different things from different people. Some people definitely tell me that the exam hurts, but here are some things that we could do to help minimize it as much as is possible. For anyone wondering, I have never had a patient tell me that an IUD insertion was a pleasant experience.
So you're gonna come see her?
I'll be down in a minute.
Thanks, I'll start IV PPI in the meantime.
That's not... Never mind. Bye.
I don't know how many people that last joke is going to fly over their heads in the beginning, but the joke there is that if you are having melena stools or any signs of upper GI bleeding, typically PPIs, which are proton pump inhibitors, are recommended by gastroenterology to hopefully reduce the stomach acid. So if there is an ulcer, for example, like a stomach ulcer, you're not causing even more bleeding. So this is, I think, like a play on the fact that they're having vaginal bleeding, and this doctor is confusing it with like upper GI bleeding, which is a really kind of subtle joke, but it's good. It's a good one. Okay, here are my final thoughts on this video and my final sell as a male doctor working on OBGYN right now, and someone that is looking to do a lot of women's health in my office, because I think it's important. I think that for a variety of different reasons. A lot of this stereotypical behavior that is memed to oblivion here on YouTube and on TikTok, especially from male doctors for the most part, it is more so from the fact that it is a lack of experience, it is a lack of interaction with this patient population, but it's so important because we can't afford to not be doing this stuff. There is a growing wait list for specialist care here, and they're busy all the time. They're seeing as many people as they possibly can. And if we're just referring people inappropriately without having had the skills to do a proper exam, take a proper history, you don't even know if it's something that you could have treated yourself. So that's my sell to everyone. I think that personally, it is one of the most rewarding parts of the job, especially when it comes to prenatal care. I personally love doing prenatal care because when I knew that I wanted to become a doctor, I decided to do this versus like investment banking or insert other big money-making job out this way, because I wanted to be a part of people's lives at the worst times to help them get through it, but also the best times. And in my experience so far, there have been few times in a patient's life that is happier than the birth of a child, for example, or when a couple comes in and they're pregnant. And I really like that stuff, and that's my salt to everyone. That's the reaction video for today. Feel free to check out the video. Let me know what you thought of today's video in the comment section below. If you guys have any experiences that you'd like to share, I'd love to hear it. Always open to feedback, like in all my other videos, and we'll see you all on the next one. So everyone take care and see you next time.